Can you hear me okay, Sean?
Yes, I have. I can.
Okay,
Have, can, do.
let me just, if you give me the share screen, I'll get my presentation up.
Make presenter. Yes. Okay, there you go.
All right, that should work.
Yes.
Okay, good. All right. You're going to do the same intro, right?
I will in about another minute.
Right.
Another minute to get back. All right, welcome back to the 11:30 session. This is going to be the 2020 Advanced Life Support Updates. Just a quick run through. I'll do these a little bit abbreviated. I think we're getting most of the same folks. Yeah, make sure if you have any questions, go ahead and put those in there, and we'll get to questions at the end of the presentation. If you're having any certificate issues, just make sure you're opening those from a computer and not your phone. Other than that, it takes about an hour, a little over an hour, for the certificates to be sent out by GoToWebinar after the session ends. And we are uploading all these to our YouTube channel for viewing later. And yes, Dr. Daya will send the link for that video that couldn't play in the last session, and then we'll forward that on to everybody. So without further delay, I will turn it over to Dr. Daya for the ALS updates.
Well, thanks very much, Sean. Again, thank you for the opportunity. I guess I have a spelling mistake. It should say Advanced Life Support. So again, we're going to talk now about the 2020 guidelines, my same conflicts of interest. And then this is the second paper. This is not as lengthy, but this is one by Dr. Berg that basically covers the Advanced Life Support Guidelines. And you should, if you are interested in resuscitation science, you should probably spend some time reviewing these, as well as how you do implement things, because it's been shown that on average changes take about anywhere from 10 to 15 years to implement in systems. So that's why we sometimes have to go over things again and again and again. All right, so let's talk about some of the things that have come up. The first hot topic that I think they tackled in this AHA update for ALS was basically double sequential defibrillation. And they actually came out with a pretty strong statement that they suggest against the routine use of a double sequential defibrillation strategy in comparison with a standard defibrillation strategy for cardiac arrest with a shockable rhythm. They gave this a weak recommendation with very low certainty of evidence. Let's talk about this a little bit more in terms of what we know about double sequential defibrillation. So basically, many systems have implemented double sequential external defibrillation in the United States and abroad. They typically will do it after someone's been in VF for at least a minimum of 3 shocks. Some papers will take up to 5 shocks. And usually it's after they've been given at least a dose of an IV vasopressor of some kind, typically epinephrine, and 1 dose of antiarrhythmic medication. And what they then do is apply a second set of pads using a different vector. Usually it's a anterior posterior, or sometimes it's left chest, right lower chest. And then basically they charge up both devices and deliver the shock. And then basically try to do this in a sequential fashion. One thing that's important is that it's impossible to do dual simultaneous external defibrillation, because these shocks are delivered over microseconds or nanoseconds. So unless you're using the same capacitor in 2 different sets of pads, it's impossible to deliver the 2 shocks simultaneously. They're actually dual sequential, so it's 1 shock after the other. And regionally, at least in our area, this has been used by Multnomah County for some time. So you can see that this is your traditional placement of pads, and then this is the right / left upper chest pads, or you can go anterior posterior, which is kind of what this is showing. in terms of location. Again, when I was mentioning in my last talk, the importance of getting this pad and this pad to be going through the ventricle are key. So why double sequential defibrillation? I think that there's a couple of thoughts and principles behind it. One is that basically that when you have VF, you've got all these reentry circuits that are happening throughout the myocardium, particularly the ventricle. And the question becomes, if you're unable to defibrillate successfully, is it because you're not getting all these things reset so that they can then start beating normally? So one thinking is that that when you're shocking in one direction, you're not catching all these sort of microcircuit, these micro reentry circuits, and so therefore you should consider dual sequential for that reason. And the idea is that you get more of the myocardium covered by using two devices. Another thought is that you're basically giving more energy, so you actually get longer duration of the shock, and so you catch, because one shock comes and another shock comes, and you basically depolarize this heart for a longer period of time, and as a result of which you get more prolonged defibrillation. And then another one is the idea is that you get even more distribution just by having two shocks. You're able to cover more of the myocardium. So it's a vector issue, a volume issue, or a duration issue. Those are the three sort of thoughts as to why this might potentially work. But when you look at the literature, it's very difficult. The pad positions, as I mentioned in my last talk, are variable. Nobody actually captures or does this correct, reports this out. There's a lot of different energies that are being used, different waveforms are used. As you know, there's all Philips and Stryker physio control devices all have different waveforms and different energies. Patient sizes are different, and that's not often taken into account. The protocols differ. Some use 3, some use 5, some use early, some late. Then there's the issue of medications, because we know that epinephrine has some issues in cardiac arrest. How do they define success? Some define it as a rhythm conversion. Others actually describe success as ROSC. And then we know very little about what happens post myocardial dysfunction. We know from animal work that if you give a large amount of energy, you do get some damage to the heart, because electricity does damage the heart, and it causes what are called micropores in the myocardial cells, and so you can get some dysfunction afterwards. And lastly, there's what we call publication bias. The reality is that if something doesn't work, you don't tend to publish it. But if something works or works once, you tend to publish it. And so most of this literature is basically case reports that have touted the value of dual sequential defibrillation. And so there's a lot of publication bias. Of the studies that have been done that have been large enough, there's one from Europe, from London, I believe, and this is actually one from San Antonio, where they gave the paramedics the option of using it or not. In this particular study, where they use a single defibrillation strategy versus a dual defibrillation strategy, the primary outcome, which was good neurological function, was actually not very different between the two groups. Neither was ROSC by EMS or survival hospital admission or survival hospital discharge. But, again, these are not randomized. These are just basically, there's what we call indication bias. Many of these studies like this, where you allow people a choice, maybe there's something about this group of patients is different than this group, and you really can't control that in the absence of randomized controlled trials. So we don't have true randomized controlled data, but there's some news, so which we'll talk about in a second. So at least for now, there's very low evidence to support it. And actually there's 2 large observational studies. But many people are using it. I think the Ben folks use a 3-2-1, so they give 3 shocks in one direction, then they'll switch the direction of the vector, and then they'll use 2 machines. So they use a 3-2-1 protocol, which kind of gets me to this next sort of study, which is basically presented at, again, that should be a spelling mistake. I should give them a hard time for making it NAMSP, not names. But anyway, this was Dr. Cheskas from Toronto, who actually has started a randomized controlled trial to help us answer this question. Does double sequential external defibrillation actually work in refractory VF? So the part that he presented at NEMSP and at the American Heart Meeting was really to study the feasibility, safety, and sample size required for a 3-arm cluster randomization trial with crossover comparing basically a strategy of dual sequential external defibrillation vector change to standard defibrillation, which would be the control group for patients who experience refractory VF. So they focused on both changing the direction of the vector and also the amount of energy, which is what you basically get. So that's the duration as well as the total coverage and the amount of energy you get from dual sequential. So these are patients who present in VF, get standard therapy, which is basically initially 3 shocks, usually amio, epinephrine, intubation, and then they're still refractory VF. At that point, they're randomized to one of 3 arms, the standard care where they continue up along the strategy, intervention arm where they change the vector, and lastly, the third intervention arm where they basically apply a second defibrillator and go ahead and deliver energy that way. The reason they did a pilot feasibility trial is they were worried about safety. They want to make sure that defibrillators are not damaged. This is important because if you carry a machine that is at risk for getting damaged, because currents, when they're biphasically delivered, like they are in current modern defibrillators, go in both directions, they can actually go back in and damage the machine. I would recommend, if you're going to use this strategy, speak to whoever your vendor is to make sure that they actually will cover it if that's the case. Zoll actually does cover this, but I believe Stryker Physio does not. The other thing they worried about was burns in adverse shocks that were not necessary injuries to anybody, and then anybody of concern that might have an issue with this, either at the EMS or the ED level. So far they presented this pilot data, which is about 150 or so patients, and you can see that when you look at their population, it's very, very similar. Age is typical of what we see in the United States as well, around 60, 65, mainly males. Bystander CPR is pretty decent, and about a third in public locations with response times. These are median, so they're about 7.5, but a little bit slower than what we're used to in our region, at least in the metro Portland area, which is usually more like 6 minutes. When you look at the other things that can influence outcomes, if you talked about pre-shock pause, post-shock pause, compression rate, compression depth, all of these were very, very similar across the group, so not much different. And time to first shock was about 11 minutes, which is pretty similar, and then intubations were slightly higher in this group, which you could argue about because we talked about ventilation in the last group. You look at other event characteristics, almost all these groups got amiodarone. They almost all got like at least 4 doses of epi before they had their dual sequential defibrillation or vector change done. And so this is kind of keeping with the fact that you're usually getting into the 3rd, 4th cycle by the time you get to the protocol that they've outlined here. Overall, what they found was that they were able to get randomization compliance from EMS in about 90% of cases. Same with both of the 2 arms. They got pretty good compliance that people are able to remember to do this. And then you look at their pilot outcomes. This is the intention to treat. This is basically not what they got, but basically what arm they were randomized to. You can see that the ROSC rate was lower here compared to the one that got a vector change, which was closer to the one that got the double sequential. This is not statistical significant because it's too small of an N or sample size, so keep that in the back of your mind. This is a pilot trial. They're actually carrying on with the larger trial at this point, and hopefully we'll know in a year or 2 what the results of that study show. When they looked at the ones that actually randomized correctly and got the correct intervention they were assigned to, you can actually start to see maybe a signal, but again, I would be cautious because these are very, very small numbers, and a bump here would change everything dramatically. So for now, we really don't know whether the strategy works or not, but there's a good randomized trial continuing on. So for now, the American Heart doesn't recommend this. And if you choose to do it, I think it's a choice your medical director makes, but I think you need to be thoughtful about the fact that if you damage a machine, that may not get covered under warranty. So keep that in the back of your mind. So again, this randomized control pilot showed that it's safe and feasible. At least this initial signals look like there were better rates of VF termination in ROSC in double sequential and vector change. And then this larger trial is actually looking at that very issue about patient-centric outcomes, what we call meaningful survival to hospital discharge. What have we done locally? I think it depends. In Multnomah County, as I told you, Dr. Ju recommends the use of double sequential, so he does it, and I think he typically does it after 3 shocks. In the consortium protocol, which is the ones that I'm more involved with and the ones that my EMS providers tend to follow, what we recommend is basically that if they've tried 3 shocks and they're not having success, to change the vector going anterior posterior. So that's kind of what we recommend at this time. Again, we haven't gone back to analyze this. This is difficult. I found that people tend to forget to do this. It's also hard to put these anterior posterior pads when you find them supine. And so this is often an afterthought, not something that they think about ahead of time. And so I haven't seen the vector change occur as much as I'd like to, but we'll see what the randomized control trial shows. All right. The next thing I think is to talk about airway oxygenation, ventilation during CPR. This again is a big issue, and it's talked a lot about in the last few years since we've had some randomized control trials that came out. And their recommendations in the 2020 ALS guidelines are that we suggest using bag valve mask ventilation or an advanced airway during CPR for adults. This has weak recommendation, low to moderate certainty of evidence. If an advanced airway is used, we suggest a supraglottic airway for adults in systems where tracheal intubation success are low. Whereas in a system that has high tracheal intubation success, they recommend either the supraglottic airway or tracheal intubation, and that's up to, and this is basically consistent with what we recommend locally, which is to really leave it to the choice of the first arriving EMS unit as to what they want to do. I think they're both acceptable options because our tracheal success rates are relatively high in the sense that we get it 70 to 80% of the time. It's not 100% of the time, but it's still a reasonable thing to do. Excuse me. All right, so what were the papers that really came out? I think we discussed this the last time, but this is the PART study. This was comparing a strategy of initial laryngeal tube insertion versus endotracheal tube insertion on 72-hour survival in cardiac arrest in adults. You can see this was a randomized controlled trial done by, again, the ROC Consortium. And we did this trial locally in Clackamas and Washington counties, Oregon, and it was basically comparing these 2 devices. You can see this is a pragmatic airway trial. So what was defined was the first airway you tried was defined. You're either in this arm or in this arm, and you crossed over. So that's what's called a cluster randomization trial. You can see that the return of pulse was higher in the King airway group. The 72-hour survival was higher in the King group, and hospital discharge to survival was better, as was functional outcomes. So in this particular study, everything favored the King airway, and it was also placed much faster because it's easier to place than initial endotracheal tube. One caveat, however, is that the overall success of endotracheal tube on first pass was much lower than other systems in the country, and also in some parts of the world where the success rates are like 80–90%. So that's why that caveat in the AHA 2020 recommendations. At the same time that paper was published, there was another paper published that basically looked at the iGel shown here versus, or it's actually an NLMA, but versus the endotracheal tube. My apologies for this one. I borrowed these slides from Dr. Callaway, who didn't pick up on that difference either. Again, when you look at this Airways 2 study and you look at the outcomes, you can see that the enrolled, and this is slightly different rather than a cluster randomization where one group does one thing and then does something else at another time. This one was basically paramedics either did iGel or they did initial endotracheal tube. You can see ROS rates were a little bit higher here. 72-hour survival was a little bit higher with the iGel, but survival to hospital discharge was very similar, and functional survival was very similar. Basically, these were not statistically significant, and the only thing that was significant was this return of spontaneous circulation. What do our consumption protocols currently say? They say you start out with that initial BBM approach that we talked about. There, again, good mass seal, capnographic breath verification, use of smart bags so you're not giving excessive volumes of air. And then advanced airways, we mainly use iGels now because we have multiple sizes all the way down to pediatrics. We do allow endotracheal intubation, and it's really a choice at this point. that I leave to the EMS providers on seeing which they want to do. But if they do the endotracheal tube, that we recommend using a VL and a plastic tube while chest compressions are ongoing. And now recently we've introduced the stiff bougie, which is easier to use with the difficult angle blade, which is the only VL we carry. Why do we have them do it during CPR while chest compressions are going? You can see that in this prior work done by Dr. Wang and his team, it's very common to see interruptions when people are trying to place advanced airway during CPR. And so to avoid, and that this interruption can be 45 seconds, 35 seconds, a total of 78 seconds. We talked about the need to not have CPR interruptions. So this is why we recommend CPR while intubation while CPR is ongoing. So lots of video cases that I watch where basically you can see chest compressions happening and you can see the intubation occurring on top of chest compressions that are continuously ongoing. So that's basically the airway study. So I think the two large randomized controlled trials really drove this decision making, and I think that that's the key. The next big area of focus was vasopressors during cardiac arrest. This hasn't changed in the 35 years that I've been practicing medicine. We still are not sure if epinephrine should be given, and if it does, how much should it be given? But basically, their current recommendation is to administer epi during CPR. This is a strong recommendation, however, it has low to moderate certainty of evidence. They go one step further this time, and that's basically for non-shockable rhythms. They recommend administration of epinephrine as soon as feasible during CPR, and that again has strong recommendation but low certainty of evidence. And for shockable rhythms such as VFVT, the initial priority is obviously a shock, and then if you can't, then you basically want to start thinking about adding vasopressors. How does the vasopressor work? Remember, the coronary perfusion pressure again is the aortic pressure minus the right atrial pressure. The epinephrine increases the tone in your blood vessels. That increases your aortic pressure, and that increases your coronary perfusion pressure. That's what you're trying to achieve with epinephrine. And still today, it's our only drug that we use. In the past, people used vasopressin. The idea that being in an acidotic state, that epinephrine doesn't work if someone's pH is really low. But those studies did not show vasopressin to be superior to epinephrine. So for now, vasopressin has basically fallen off. And it's also hard to find and very expensive these days because it's not manufactured as much as it once was when it was a drug that was readily available to us. So what's this all based on? So this is based on essentially the Paramedic 2 study, which was published by the folks from England. This is similar to the Airways 2 trial in the sense that paramedics were recruited to randomize patients into either the placebo or the IM or the IV epinephrine arm. And you can see that they enrolled 9,000 patients who got either epi or placebo. And you can see the survival to hospital admission was much lower in the placebo group compared to the epi group, but the survival to 30 days was 2.4 versus 3.2, and favorable function was slightly better in this group. Now, one thing I'll point out is these numbers are very low. In the United States, we see survival rates ranging from somewhere between 8 to 15 to 20%, depending on what system you are. So it sometimes makes you wonder whether the persons that they were studying in this particular trial actually were the type of patients we see on a regular basis. So that's something to keep in the back of your mind. With COVID, it's been all off the board since survival has dropped dramatically in the country with COVID. But my hope is that once we get through our pandemic, we'll be able to get back and achieve high survival rates. This was looking at neurological function. One of the things we measure, something called a modified Rankin score. It's how well a person can function independently at home. 6 means death, 0 means no deficits. Most people take 3 or less to be a good sign. And you can see when you look down in here, the groups are pretty comparable when it comes to their functioning status at home in terms of epinephrine versus placebo. Shown another way, this basically shows you no disability versus disability, and you can see that essentially you get a slight increase in the number of people with no disability, but you get a significant, you get a slight increase in the people with no significant disability in the epinephrine arm, but you get much more people with disability. So the question is, are we bringing hearts back, but we're losing the brain? And is really what effect is this having? So this question remains unanswered, and we'll need more studies and more trials to try to address this issue. But it remains a big question as to whether should we continue to use epinephrine? If so, how? And this is what the Paramedic 2 trial raised questions about. However, simultaneously, I think, and you can see it in the 2020 guidelines, some work was done also to, again, looking at some of the ROC data, looking time to epinephrine administration, particularly for non-shockable rhythms. For shockable rhythm, it's very clearly the priority is to start CPR, take a look at the rhythm, and then deliver a shock if they're in VF. But for non-shockable rhythm, the real question is epinephrine is your only choice that we have. And again, since we're trying to achieve that CPP threshold before you can get ROSC, what impact does it have here? So this was work done, led by Dr. Matt Hansen, who's a pediatric emergency physician, also Delta emergency physician, OHSU. And you can see that the survival rate here, which is similar to what you saw in the Paramedic 2 trial, was dramatically declined the longer it took you to get epinephrine on board. And these are in 2-minute intervals. So this is one of the largest data sets, observational. It's not high quality because it's not a randomized controlled trial, but the point being that the sooner you get the drugs, the better your survival. But unfortunately, most of the times we don't give epinephrine until we get 10 minutes into a call. Same data shown differently. Again, if you can get the epinephrine within 10 minutes or less, you get probably better survival. But after that, it goes down dramatically. And this has been confirmed by other people as well. This is Dr. Donino out of Boston looking at in-hospital cardiac arrest. This is pediatric in-hospital cardiac arrest from the registry that the American Heart maintains. Again, this is shockable from the in-hospital cardiac arrest data. In all of these cases, it's shown that if you delay epinephrine, your survival drops. So the idea is if you're going to use epinephrine, give it early and try to get it on board quickly. Lastly, one paper from Japan, from the Osaka system, that again shows that if you can get epi within 10 minutes, and this is actually time from call until administration. So the 911 call, so you have to have a very rapid response, a very rapid delivery method. You can see your crude odds ratio of survival are much higher than if you give it further out, where it drops dramatically. And this is not surprising because basically, as I said before, the epinephrine goal is to increase your aortic pressure and hence increase your CPP by increasing the aortic pressure. But the problems with epinephrine are numerous. One is that it actually causes myocardial energy consumption, which leads to tachycardia, tachydysrhythmias. It actually may even make VF more may make VF recurrent because you're basically stimulating a hypoxic heart. So that's that mismatch between oxygen delivery and consumption. But it's the best drug so far we have that targets aortic pressure. We also know that it uses up energy both in the brain and the heart, so that drops myocardial ATP stores and brain ATP stores. And then in the brain, you actually get this micro constriction at the micro blood vessel, which really causes a lot of ischemia, which kind of explains a little bit about why we might get the heart back, but we don't get the brain back. So people have been working a lot to try to see if there's something they can do to counteract this effect of epinephrine, and that work is ongoing at this time. There's a lot of unresolved issues with epinephrine. What's the best dose? The folks in Seattle use different doses. They use 0.5 if it's a shockable rhythm. They use 1 if it's a non-shockable rhythm. What's the frequency? Some folks from New Mexico reported a study a few years ago where they had a shortage of epinephrine, prepackaged epinephrine, so they changed the frequencies to 1 every 10 minutes rather than once every 5 minutes. And surprisingly, their survival did not change. In fact, it slightly improved. And then lastly, how do you get time reduced to administration? There's a lot of interesting ideas here. I mean, there's one study that's been ongoing, recently presented from Utah, where they're looking at giving an IM shot of epinephrine into the muscle right off the bat as soon as you get there, so you can try to get that epinephrine into the system. But we also know that muscle perfusion during CPR is not the best because your body's shunting to protect the heart and the brain. So, you know, these are all these questions about epinephrine that we don't know, and there's many more that we're still trying to understand. So that's kind of where we stand today on epinephrine. It's still recommended, and for non-shockable, you need to try to get it in as soon as possible. For shockable, it should be given after you've at least taken a couple of attempts at defibrillation, establish vascular access, to try to optimize that coronary perfusion pressure. Antidysrhythmics for cardiac arrest, basically here, nothing much has changed. So the large ALP study that was published now about 5 years ago, or 4 years ago, essentially showed that amio or lidocaine were essentially equivalent for refractory VF. So these are now both recommended. In the past, the guidelines would focus on amio, but now that ALP study came out, there's enough data to support the use of lidocaine. Magnesium, which we used to use in 10, 15 years ago, is now basically dropped. The only one area that I use magnesium is if you think you've got torsades, which can mimic VF. The difference with torsades is that basically when you post-shock them, their QT is pretty prolonged, and if you can pick that up, that allows you to use magnesium. It's a reasonable option then. And then they made a point that there was not enough information about prophylactic antiarrhythmics, particularly lidocaine, after ROSC. And this question has come up very recently for me in one of my cases. We just reviewed this last week. So this led me to sort of pull out this paper by Dr. Kudenchuk from Seattle and his team, looking at prophylactic lidocaine for post-ROSC care of patients with out-of-hospital VF cardiac arrest. So what they did was they looked back at their registry data, and they looked back at over 12,000 cardiac arrests in a long time period, almost 16 years here. And what they did was they looked at the patients who had witnessed VFVT and those who got ROSC, and then those who got prophylactic lidocaine after getting ROSC versus those that didn't. And the idea being here that you've got an irritable heart that's been resuscitated with a shock, and now will that person go back into VF again or not? And does it make sense to give lidocaine? In the past, in the old days, we used to use lidocaine in people who had MI to try to prevent this from occurring, but that practice got stopped because those individuals, some of them ended up getting bradycardic from the lidocaine, and so we stopped doing that. But the question now becomes, if you shock them successfully, should you give them a dose of antiarrhythmic? And lidocaine is the easiest to use because you can push it, and it's much faster in terms of its delivery mechanism today compared to amiodarone. You can look at, when you look at the outcomes from this particular study, you can see that recurrent arrest in the group that had an initial shockable rhythm or initial non-shockable rhythm were both much lower if they got the prophylactic lidocaine. If you got prophylactic lidocaine, you're more likely to be admitted alive and you're more likely to be discharged alive. The downside is when they did some propensity analysis, this didn't completely hold true. So again, this is observational data, not randomized controlled trial data. So for now, we don't really know the answer about prophylactic lidocaine, but some of us do use it, and our protocols locally say that if you have ROSC before you give an antiarrhythmic, so it's a one shock success with ROSC, like that patient we were talking about in the last session, we looked at the pre-shock pauses. That patient got some antiarrhythmic for this reason. And we leave the choice up to the paramedic. The one caveat is if it's a bradycardic rhythm, such as a block or a slow rhythm, then we don't recommend, because there's a higher risk of getting into something like asystole as a result of giving an antiarrhythmic in that patient. Moving on, let's talk about drug delivery, since I've mentioned how important it is to get drugs on board, particularly epi early with people who have non-shockable rhythms. The question is, what's your best route? So the HA 2020 guidelines actually did take a stand on this one, and they recommended that IV access be the first thing you attempt instead of IO. The evidence is weak, and again, the certainty is low. If, however, accesses at IV are unsuccessful, then they recommend going to IO as a route for drug administration. But again, the evidence is weak and the evidence is very low in terms of its certainty. What's this based on? This is based again on a series of observational trials that have been done out in EMS systems that have implemented IO. The challenge here is that IO is often tried after IV. So there's something called confounding by indication. So you're trying these in a group of patients that are already more difficult to resuscitate. So is it really fair to compare them? But when you look at this both from the system in British Columbia, the systems in Seattle, they both found that IO access was associated with lower survival and poor neurological recovery. In our own work, we actually looked at the ALPS trial and we looked at the difference between IV versus IO. And we found dramatically some interesting findings that when you give amio versus placebo or IV versus lidocaine versus placebo IV, you had much, much better survival. This actually supports the use of either of these drugs in shock refractory VF. But when you give it IO, it really didn't make any difference. And so, what we're all trying to do is trying to do the right thing. And so IOs have become popular, but the question is, do they really work? And if they do, what's the best way to utilize them? This is looking at, so this was looking at survival hospital discharge. This was looking at neurological function going home. And you can see again, the same differences persist, maybe slightly less powerful for lidocaine versus placebo, but still the point being that giving drugs IV seems to be the best option if you can do it. So one of the things I recommend is that even if you use an IO, continue to look for an IV. And once you get an IV, use that as your primary route for drug administration during cardiac arrest. One more paper that again also came out from the consortium's continuous compression trial, which we talked about before. This was done by a team out of University of Texas Southwestern in Dallas. And they again found exactly the same rhythm, that whether you, the same findings, that whether you had an initial presenting rhythm of shockable or non-shockable, whether you're witnessed or non-witnessed, that if you used IO route of drug delivery, you had worse outcomes. And that applied, this is mainly applied to epinephrine. So I think that overall, the current thinking is that you should go for the IV up front if you can get it. If you can't, then your second choice should be the humoral IO. This takes a little bit of skill to practice and get used to, and I think it's fine. I recommend they go for this very early, but they still work for an IV. And if you can get an IV, then you go back to using the IV. And your third choice is the tibial IO. Now, there's some good data that's come out of the military that's looked at these different techniques. And what they've shown is that when you give a drug in the tibial IO, there's a delay to the peak concentration that hits the heart. So it takes longer, usually 2 or 3 minutes longer for the blood to actually get to the heart. And secondly, the amount that you get in terms of the height of the concentration is lower. So this data makes me suggest that if you're going to use this particular route, that is the tibial IO, you may need to rethink the dose of epinephrine you're using and how frequent you use it. So these are things to think about. And also remember that when you're doing CPR, technically, the blood flow is only going when you let go of the chest, because otherwise you've got forward blood flow. And you've got these one-way valves as well that kind of exist in this whole system. And that, is the drug actually getting there, or is it a lot of it staying there? We also know that when you give a drug here, a lot of it stays in the bone and doesn't get into the heart. So there's a lot of questions about IO, and that's why I think the American Heart took the stance this time around of saying, let's go with IV if you can do it. I want to finish up talking about post-ROS stabilization, because I think it's something that we don't pay enough attention to, and something we're trying to pay more attention to locally here in the consortium. So what we have learned from, again, much of the ROC work that we've done is that rearrest is actually exceptionally common. cardiac arrest. So particularly VF, and in the ALPS trial, what we found was that rearrest was very, very common. And this is our post-ROSC protocol, which I'll come back to in a second. So rearrest occurs in between 20 to 40% of patients. So if you get them out with one shock, there's a good chance that they're going to rearrest on you. And if they do, their survival is always uniformly worse. It doesn't matter whether you look at ROSC, survival with neurological function. Each one of these is going to be lower if they had recurrent VF. So we want to avoid recurrent or rearrest as much as possible. And the question is, how do we best do this? These investigators from Pittsburgh who looked closely at the ALPS data found that the only thing that basically could prevent rearrest seemed to be a good CPR quality. So getting the best blood flow was the main thing that basically prevented a lack of rearrest. But this has led people to start thinking about, should we simply rush off the scene, or should we actually try to do something differently? And so what we've introduced in the local regional protocols is essentially this concept that once you get someone back, you take a little bit of time to make sure that they're stable. So you make sure that they're intubated if needed, that you've tried to get their oxygen down so that they're not getting hyperoxia, because we know hyperoxia is damaging to both the brain and to the heart if you get reperfusion injury, which is what happens after you reestablish circulation. We want to make sure that the end-tidal CO2 is being monitored. And then you basically want to make sure that if you've intubated them, that you've got appropriate sedation as much as you can after, so that the tube in their throat is not causing them pain and discomfort. You want to make sure you give them the antiarrhythmics if you need to do so. We talked about prophylactic lidocaine. And then you need to check their blood pressure. And what some systems are doing is repeating pressures every 3 minutes up to 3 or 4 times on scene to make sure that these are adequate. And if not, then you need to basically go ahead and start treating their cardiogenic shock. And you do that with a combination of fluid plus or minus push dose epi, but more likely in the long run is going to be a norepinephrine drip. All of these things need to happen. And then you need to also think about getting your 12 lead, and then you need to think about getting some cooling measures started, typically externally in our environment here, and then decide where you're going to go, because some of where you go depends very much on what the 12 lead looks like, depending on how much support you have in your region. So this entire concept of taking time post-resuscitation to make sure the patient's stable is something that we've not paid attention to. So the idea is that just because you get them back, the next thing is not just package them and rush to the hospital. You need to make sure that you get them to the hospital still alive without a rearrest, which can affect up to 40% of cases. The other thing we recommend doing is if you have mechanical devices, to place that on these patients, even if they're post-ROSC, so that if they do rearrest en route, you can at least start mechanical CPR. That's much more efficacious and safe in a moving ambulance. So that's the reason why we recommend that. The other reason that I think it's important to spend some time at the scene is one of the things that we have tried to do post-ROSC is figure out what causes cardiac arrest. Most of the patients we see in the United States, about 60 to 70%, have underlying coronary artery disease as the cause of their sudden cardiac arrest and sudden death episode. So getting an ECG is important early on, but you also know that if you get an ECG from a heart that just got shocked and is still getting some very poorly oxygenated blood perfusing, it's probably going to have some signs of ischemia that are not actually reflecting a STEMI or any underlying coronary artery disease. And so these authors recently came out with this paper in JAMA Open, which is an interesting study from a combination of people in Italy and also from Austria. It's fascinating to see that they actually tried to look at this. So what they did was they took all these patients that they were seeing in their registry, and they'd been taking most of them to the cath lab for many years, but then they would look at the cath lab findings to see did they actually have an obstruction or not. And what they found is it really depended on when you got your post-ROSC ECG. So if you got your post-ROSC ECG super early, the chance of a false positive finding was much higher than if you waited about 10 minutes or so to get your post-ROSC ECG. So, these authors recommend that, if you do get ROSC, stabilize the patient, package them, think about all the things we talked about, support hemodynamics, make sure you got a good IV, make sure all those things. And IV is easier to find, as you know, after they've got ROSC back. And then get your ECG. So don't prioritize this up front like we sometimes do, but wait a few minutes, because that heart, after it's been shocked and it's now reperfusing, it's going to take some time for some of the ischemic changes that you might get just from cardiac arrest to resolve. And so getting an ECG way too early can actually confuse you and fool you and end up with a false positive trip to the cath lab. So very interesting, provocative thinking that maybe fits with the idea that we need to spend some time thinking about post-ROSC and all the steps we do. Another thing I didn't talk about a lot is use push dose epi. We are using it a lot in our system today post ROSC. So sometimes someone's got a blood pressure of 85, 90. You've just shocked them back. They're a little bit borderline. A small dose of epi, not a milligram, but a push dose epi of 10 to 20 micrograms. Sometimes enough to support the circulation, just as that heart is trying to pump and get back. It's enough to keep things going until you can get your norepinephrine drip if you need that for cardiogenic shock, and we can get them back to normal. So this is the ALS summary. I said it was going to be shorter, partly because I wanted to leave time for questions, but basically dual sequential is not being currently recommended for shock refractory VF. If you are using epinephrine, which we all should be because it's continuing to be our primary drug of choice, then remember that with the non-shockable rhythms, you want to get this on early as possible. Lots of different ways that we're still trying to figure out how to get it on. Airway-wise, BVM, SGA, ETT are all acceptable options. You need to do each of them well, and you need to monitor how well you're doing with each of them, which is the caveat. If you have shock refractory VF, VT, then either lidocaine or amiodarone can be used in those circumstances. You can consider prophylactic lidocaine after achieving ROSC if someone has not received any antiarrhythmic during the resuscitation, but the evidence isn't as strong as we'd like it as yet. Vascular access wise, we prefer you go for an IV, but realizing it's difficult. It's fine to go for an IO. If you're going to go for an IO, go for the humerus first, and then continue to work on getting an IV. And lastly, rearrest is a common problem, so don't pat yourself on the back after you get pulses back. Now you got to keep that patient stabilized and safe so you can get them to a definitive care facility for further care. So consider some post-resuscitation measures. We've actually developed a checklist of things that people go through to make sure that these are covered. And the idea should not be that you quickly rush off the scene after you get someone back, but you actually spend some time trying to stabilize them and then head off to the hospital. This is controversial. It's not proven scientifically. We're actually trying to do a randomized controlled trial to actually prove this. It's called the stay and stabilize approach as opposed to rapid transport. Diesel is a very common thing we like to use in EMS, somehow thinking that the hospital will make everything better. It can in many circumstances if you deliver them a good patient, but if you simply rush off the scene and deliver a patient that's rearrested, they're not going to have much more success than you initially had. So once you get ROSC back, take some time to make sure that that patient's stable. With that, I think I've left here 14 minutes or so for questions, and I'll summarize with a couple of our survivors. This is what cardiac arrest research and cardiac arrest care and EMS is all about. It's a young 16 or 18-year-old. I think he had WPW. This is a teacher, and two of our survivors from years back. So these individuals keep you motivated to keep working at this, because I'll tell you that of all the things you do in EMS, taking someone who's basically dead and bringing them back and bringing them back to a functional life is one of the most amazing things and experiences you'll have. And in good systems of care, this is not something that is a rare event. It happens on a regular basis. In Seattle, King County, they say 1 out of 5 people that has cardiac arrest. And I think many parts of the country could reach that if we just had a good system of care. All right, let me stop there and we'll take questions.
Okay, thank you, sir. First question. the first question was the IM site for epi. Do you believe there would be a difference in outcome for IM epi and arrest? Would that make any difference?
Yeah, so, it's a great question. So I actually asked this to the guys from Utah that presented their paper, and they're not sure. We actually studied this briefly in the ROC consortium in an animal model, and we were not able to show that this was effective. But it's an intriguing concept idea that if you give a large dose IM, even if a little bit gets in, it might be enough. Obviously, you'd have to look at safety, you'd have to look at muscle necrosis, you'd have to look at a few other things afterwards. But in the study they presented out of Utah, they were giving 5 milligrams IM into the thigh, kind of like you do for anaphylaxis. And it's an intriguing concept. I don't know the answer to this. When we did this in the rocks, like I said, consortium in an animal model, it didn't work. So I don't know the answer to that, but it makes you think that is a fast way of getting it. And the nice thing about the IM part is you could attach it to an AED and a CPR mask and basically have it ready to go. But the other question is where you give it. Do you give it in the lower extremity or do you give it in the upper extremity? Do you give it in your deltoid? Do you give it in the thigh? And so those are unknowns. So a lot more to come.
The next one is more of a PALS question than an ACLS question, but just IV before IO and PEDS as well?
Yeah, that's a tricky question. So I'm not a pediatrician and I don't practice PEDS anymore, but for the EMS persons, I think so. I think in all of the resuscitation, what I teach them is to go for an IO if you have to early on. That's completely fine, but don't give up on the IV. So the idea is that go for the IO, and in children you can't use the humerus, so you're stuck using the tibia. But realize that if you can get an IV, it's important. And then down the line, we may get some more data. My thinking personally has been, after looking at the data, I'd love to do a study in which they change the dose that you give IO. So you saw 5 milligrams of IM. I wonder if you could compare a dose of like 2 milligrams IO versus 1 milligram or half a milligram IV. Whether that would be better, because I think issues really come down to the fact that the drug does get into your system. It just takes longer to get into the system. Now, this is in animal models of non-cardiac arrest, but it's very intriguing that basically it takes longer, not surprisingly, for drug to go from your bone down in your leg all the way up to your heart, where supposedly your drugs are working to increase your CPP. So I think you don't have much of a choice in children. I think it's completely fine to use the tibial. I would use that. I think, have I had survival from tibial IOs? The answer is yes. So I don't think it's not completely working. The question is, why did they survive? Is it the good CPR did I do? Was it the drug? Was it the defibrillation? Was it my pad placement? There are a lot of unknowns. But I think that in kids, you're sort of stuck, because IVs in children are very difficult. No easy answer there. Fortunately, cardiac arrest in children is primarily respiratory. So, all the things we do to try to remove and reverse, improve CPP is probably less validated in children than it is in adults.
All right. The next one, instead of delaying ECGs in ROSC, just placing the 12 lead and just doing serial 12 leads, I assume you'd think that would be a good idea.
Yeah, in fact, that was the recommendation. What they recommended was that you get an initial ECG as you're leaving the scene, just before you leave the scene, and then you get a second one just as you arrive at the hospital. And that's what they're recommending. But they're recommending delaying that initial one as long as you can. They're recommending 8 minutes in that paper. But that's, again, retrospective observational data. It's not randomized controlled trial, so it's not easy to prove.
All right. I know I don't believe AHA made any recommendations on this. So I don't know if you want to speak about this, but the heads up, CPR, and then the ITDs.
Yeah, so heads up CPR, I didn't comment about it this time. I don't know if I talked about it the last time, but heads up CPR is becoming popular. It's being used a lot. Again, the level of evidence behind it isn't there because of the reasons that we talked about. So many of these systems that have implemented heads-up CPR have implemented a bundle of care. When you do a bundle of care, you bring all these things together, and then you can't tell which one is making the difference. And that's the challenge of when you implement multiple things. So you're saying everything makes a difference. Well, the problem with the bundle of care is that essentially each of those elements has a cost to it, right? So an ITD is $120. An IO needle is $140 at this point. A Lucas device for mechanical CPR is what is recommended with the use of the heads-up device, and they usually recommend the Lucas device. So that is expense as well to the system. So you can't really do heads-up CPR without a Lucas, without the ITD. And so that, and then you have to have the heads-up device, which in itself is a few $1,000s. So this is more equipment, and the question becomes, is this where you put your money in? Or do you put your money in on dispatch CPR, rapid response, timely defibrillation, AEDs in the community, and post-ROS care? And I think that's the tough question. I think, you know, if you could save everybody in the world and unlimited money and didn't have to make economic decisions, you could pick any, you could do all of them. But when you have to pick and choose, I think you as a leader in an EMS organization have to decide the fact that, you know, there's a lot of good stuff, but if I was to make the biggest impact in my system, it's teaching someone to do CPR while they're after someone's collapsed in front of them, and trying to get to them as quickly as we can. And I really like law enforcement, AEDs, and CPR training in the rural parts of Washington County, where they get there in their fast vehicles, often you know, much faster than a fire engine can. And even though an ambulance is faster, as you know, the fire engine is not a big fast truck, so it's going to take time to get there. So, so I think you have to ask yourself where you want to prioritize. One thing to be careful about in medicine in general is don't get enamored with fancy technology and devices. They don't fix everything. They won't fix if your chain of survival has lots of weaknesses in it that you need to strengthen first. Fix those before you start working on the sort of the higher cost items.
And I'll just answer there was a question, what is heads-up CPR? It's basically you're putting the patient in kind of a semi-Fowler's position during compressions to increase blood flow.
Yeah, so the concept there is again, it's a little bit different. I didn't get into this because there's sort of, so remember that we talked about coronary perfusion pressure, right? So that's the difference between the aortic pressure and the right atrial pressure. Remember, the cerebral perfusion pressure of the brain is the difference between the mean arterial pressure and the ICP. So when you raise someone's head up, you drop the ICP and you improve brain perfusion. So the idea behind heads-up CPR and the animal model is pretty impressive. I mean, I've been out to Keith Lurie's lab in Minneapolis, and it's pretty impressive what they can do with these animals and bring them back. I mean, they can put them in arrest for 15 minutes in asystole and then start heads-up CPR and bring them back, and they can show great blood flow to their brain and great blood flow to their heart, and they're able to bring them back. But I think that that's an animal model where everything else is controlled from what we talked about before. They can start mechanical CPR, get high quality CPR going. You're not dealing with that situation. You're dealing with, you know, a completely different scenario. And so when you don't have all those other things optimized, can you truly say that that'll work as well in your system? I don't know the answer to that. And that's the tough part. But the idea here is that you get the combination of heads-up CPR gives you better brain perfusion, combined with everything else you're doing to get better heart perfusion. And that's where the ITD comes in, because it increases intrathoracic pressure, increases venous return, makes CPR more effective. So the idea that you get better blood flow to the heart and brain with the combination of the two, does that lead to better outcome? That's a tough question. And I think that there's not enough randomized control trials on this. It's a tough question. If you have lots of money, and it's not an objection, I think that you could try it.
All right, we'll do one more question in here. I don't think the recommendations have changed on this, but meds via endotracheal tube still not a recommended route.
So so in peds they recommend that if you are really having difficulty and you can't get an IO, it is recommended. You have to use larger volume, just like before, but not in adults. It doesn't work because really to get a drug absorbed, you have to get it into the lower alveoli, and it just doesn't. Most of the drugs you give stick in the upper airway, which is why they're in your bronchi and trachea. That doesn't have great circulation. It's your gas exchange and your perfusion is occurring at the alveoli level, and you just don't get enough stuff down there. So that used to be a strategy we used 30 years ago. I don't think it works as well as one would like it to work, and I think the data just hasn't supported it. But it's still an option in children where IV is a little bit more challenging, and IO can also be challenging if you don't have the equipment. It's a good question.
All right. Well, with that, I think it was the end of our questions. We'll let everyone get off to a half an hour lunch break. Thank you, Dr. Daya, for both your presentations today. And you have any parting words for us?
No, I think continue to keep up your good work. I think it's all about remember that this is a journey. We're trying to get better. And when I first started at TVFNR, looking at our data back in '98, we had a 12% VF survival rate and I think a 5% overall survival rate. And when we looked at our data 2018, which was about 20 years later, we were up to 40% VF survival rate and 15%. So we quadrupled our VF survival rate and tripled our overall survival rate. So it takes time, but you got to pay attention to the details. And again, don't get caught up with machinery. Machinery will not fix what you can do with your hands and with time and getting there quickly. So it's really important that you think it through as a system, and that you're trying to do your best as you can, and put emphasis where the returns and rewards are going to be much higher.
Okay. Well, with that, we will end this presentation. We will all see you back in about a half an hour.
Thank you. I'm gonna have to figure out, Sean, how to share that video with you. So let me work on that. Okay.
Okay. Thank you, sir.
Thanks.